It's my pleasure to introduce our keynote speaker today. Our keynote speaker is Dr. Price. Dr. Price will be talking about patient engagement in healthcare and decision-making. Very appropriate session. She'll be using audience response as well, so there are clickers on the table. Dr. Price is the Chief Nursing Executive and an advanced practice nurse in the Women's Cardiovascular Health Institute at Women's College Hospital in Toronto. Dr. Price holds a PhD and an acute nurse practitioner certificate from the University of Toronto, and she is certified cardiovascular nurse with the Canadian Nurses Association. Dr. Price holds an adjunct lecturer appointment in the Lawrence S. Bloomberg Faculty of Nursing, University of Toronto, where she is involved in graduate faculty education. She is presently a co-investigator on the ADAPT study, Avoiding Diabetes After Pregnancy trial, which is funded by the Lawson Foundation, the Canadian Diabetes Association, and the Canadian Institute for Health Research. Dr. Price will be speaking to us today on patient engagement in healthcare and decision-making. Dr. Price.
Thank you very much. Am I too loud? Okay. First of all, I'd like to thank you for the very kind invitation to be here. It's a huge honor. Notably, Clinical Updates is actually where I started my academic career, doing my first presentation here after I graduated from graduate school. And I spoke about how patients make decisions about smoking behavior. So again, that shared decision-making that we're going to talk a little bit about. I'd like to thank Emil for your kind words this morning, because you're really setting the stage for me. My career for the last 25 years has been in cardiac rehab, specifically for women, but certainly we love to hear you talk about cardiac rehab. And also for our breakfast speaker, also talked about the importance of patient engagement in decision-making and the importance of using patient education. So kind of a nice lead-in for me. I have no disclosures to make today. So why do we talk about patient engagement? So patient engagement has been called a critical part of continuously learning health systems. It's necessary to the redesign of healthcare systems, and it's been termed as the holy grail of healthcare. We've been talking about the expression, nothing about us without us, for over 30 years now. It was first coined by the disability rights activists to convey the ideas that no policies should be reached without full participation of the representations of all stakeholders. More recently, this has been adopted by patient communities seeking broader involvement in the healthcare system. And although the drive is for patient involvement, and it's come from patients, the medical community has much to gain from this. Some researchers have actually dared to say that patient engagement is the next blockbuster drug of the century. Carmen et al. Describe patient engagement as patients, families, their representatives, and healthcare professionals working in active partnership, and also describes it as a continuum. For myself, I think about why patient engagement because of my career in cardiac rehab. That's what I've done for the last 25 years, is work with patients. It aligns closely with working with women and heart disease, and it aligns closely with working with chronic disease patients, because really we see these are the patients who are actually managing their own care at home, and as healthcare providers, we are providing them the support to enable them to manage that care. And Emil spoke nicely to that, how 8 years later, his cardiac rehab program is still that ongoing support, who he has peers and who he can go to questions with. So today, these are our learning objectives. We're going to talk about the benefits of patient engagement in research. We'll talk about patient-centered approaches to decision-making, and we'll integrate some of the needs of patients, including gender equity, ethnicity, Indigenous heritage, and geographical challenges, with the caveat that my expertise here is around the gender equity and involving women. And I think it's important to note that 25, 30 years ago when I started in this field, women were really considered as not having heart disease and not really involved. And thanks to Avril for pointing out the work on women and heart disease that's going on now. I'll be talking from the literature, but also trying to weave in some of my experience that we've had over the years, some of the things I've done with patient engagement that has worked, and clearly some of the things I've done that have not worked. I'm actually going to start with the patients as partners in care. So patient engagement is actually not a new concept. It's grown out of the concept of patient-centered care and shared decision-making. And shared decision-making was first a term coined in 1982. It's talking about clinicians sharing their best available evidence, supporting patients to consider options, and achieving informed preferences. Patient-centered care arose out of the Picker Institute in 1988. And I can remember in 1988, I was actually working in coronary care and intensive care units, and we were starting to talk about patient-centered care in the hospitals in Toronto. But what we were talking about wasn't necessarily getting patients involved in decisions. It was really about bringing the care to the patient and trying to make it so the patient wasn't traveling around the hospital, but that we would try to do everything for the patient. But that really wasn't what patient-centered care was about. Patient-centered care, according to the Picker Institute, was really calling attention to the need for clinicians, staff, and healthcare system to shift the focus from disease and disease management back to caring for the patient and the patient's family. It reflects a movement from the paternalistic, where the clinician knows best, to a more holistic way of delivering care, listening to the patient, trying to elicit values from the patient, acknowledging that patients are biopsychosocial and physiological wholes, and that we should be seeking to ensure those needs are met and be respectful and responsive. Patient-centered care and shared decision-making is grounded in the ethical paradigms of autonomy and the right to self-determination. It really moves to viewing the patient as an active participant in their own healthcare team who should be involved in all decision-making. The Picker Institute, in partnership with patients and families, identified 8 characteristics of care as the most important indicators of quality and safety. And these were done through research and really from the perspective of the patient and their family. So their 8 perspectives were respect for preferences, values, and expressed needs, coordinated and integrated care, clear, high-quality information and education for patient and family. And certainly we heard Emile talk about that, and our breakfast speaker talked about that, and talked about the good work that Heart and Stroke does in providing evidence-based patient education materials. Patients and families want physical comfort, including pain management, and this was really where the pain management directives came out of, and they drive Accreditation Canada now. Patients want emotional support, alleviation of fear and anxiety, the involvement of family and friends as appropriate, continuity, including through transitions, and access to care. Successfully addressing these dimensions requires enlisting patients and families in the design, implementation, and evaluation of care systems. Practically, though, what does patient-centered care or shared decision-making mean? Patient-centered care is respectful and responsive to individual patient preferences, their needs, and their values. It acknowledges that patient values guide all clinical decisions and highlights the importance of patients and clinicians working together to produce the best possible outcomes, and those outcomes are guided by the patients themselves. Patients and families require education and support, though, to make these decisions and to participate in their own care. And how do we do that? Typically, we think about involving patients as partners when we come to fateful healthcare decisions. And fateful healthcare decisions are those where a patient is at a crossroads of medical options. There's diverging paths and very different and important consequences of these different paths that will have lasting implications. This might be a time of major surgery. It might be when a patient is contemplating being put on medication for the rest of their life, or talking about certain screening or diagnostic testing that can trigger cascades of various and stressful interventions. For some decisions, there is clearly a superior path, and patient preferences may pay little or no role. And we think about when a patient presents with acute appendicitis or a fractured hip or bacterial meningitis. We can give patients a very clear path, and making a decision can be considered quite easy. But for most of the decisions, there may be more than one reasonable path. And that path includes doing nothing. So we think about, in cardiology, starting a patient on lipid therapy for the rest of their life. What are their options? Could I try diet? Could I try exercise? What if I do nothing? When will you check me again? What does that mean? So these different paths entail different combinations of possible therapeutic effects and side effects. And David Eddy has argued that there is very few interventions that would be considered standard, which would mean that patients would universally agree that the outcome is desirable. So that the bar is very high, and we must offer options to patients in most decision-making situations. So how does shared decision-making work practically? And our initial speaker talked about decision aids, online or on paper, but really it's about clinicians asking some different questions and becoming more of a coach as opposed to a doer. Instead of asking, what is the matter, start asking, what matters to you? Sorry about this slide. This is actually Carmen's framework. I talked to you about it earlier. It really just says that decision-making is a continuum. So some patients and some decisions will require very little shared decision-making, and in others, the patient will become the leader and the partner in decision-making. There's two frameworks that people use to involve patients as partners as care. One is called choice talk, opinion talk, option talk, and decision talk. And the choice talk is ensuring that patients know reasonable options exist. And this is giving them good information about treatment options, explaining why there is a choice, eliciting what their personal preferences are, explaining that treatments have different options, and some may mean more to different patients. And of course, you also have to explain that there's also uncertainty. So we don't necessarily know that every treatment is going to work for every patient. Option talk is really checking their knowledge, listing options, describing those options, and looking at the harms and benefits and providing decision support tools, supporting and ensuring the patient understands what you've talked, so that talking back. And then discussion talk is focusing on preferences, what from the patient's point of view is the most important, see if you can elicit a patient, and try to move on to a decision. Is the patient ready to decide? Do they need more time? Are there more questions? Are you ready to make a decision? A framework that we use a lot, and a lot of people do use because it's part of the Stanford Chronic Disease Self-Management Program, is called Take Part. And it stands for teaching or explaining to patients that before they attend an appointment with a clinician, they need to be prepared, ready to ask questions, repeat, so explain to their provider what they've heard, and then take action. When I explain this to patients, we talk about the taking action, and that sometimes taking action will mean, okay, the clinician has explained something to me, I agree with it, and I'm going to do it. So tell your clinician you're going to take the NOAC, or you're going to continue on the warfarin. But take action also might mean, you know what, I'm not going to do that. So tell your clinician, I don't want to do that, it doesn't feel right to me, what are my other options? Because in reality, there's always other options that clinicians can offer, and it's our job to do that. I don't know if anybody follows Carolyn Thomas. She's a Canadian patient with heart disease, and she blogs a lot, and she's well thought of in the US and has been down to the US to help run some women in heart disease groups. And she's been blogging and tweeting over the last month about engaging patients in healthcare. And she talks about the 4 questions patients should ask, being, what are the chances it will help me? What are the chances it will harm me? What are my alternatives? And what if I just do nothing? So those are things, and these are things that we actually in rehab teach our patients to say when they come to see you. When they come to you to help have a discussion around their health care, we actually help them write down questions and write down these questions about what are my alternatives. So patients as partners of healthcare, there's a growing body of evidence to suggest that patient engagement can lead to enhanced adherence to treatment plans, better health outcomes, and can also increase patient satisfaction and healthcare services. New research is showing that it may indeed help control healthcare costs as well. As we look at the high cost and the increasing cost of healthcare spending that is not necessarily related to an accompanying improvement in outcomes, there is a growing belief that patients are at the core of our healthcare system and as such can be part of the solution and help us with that. So in our practice, we've done a couple of studies talking to women about what they want in healthcare. And one was a group where we actually spoke to women in our women's-only cardiac rehab, and we asked them if they were, they felt they were being empowered. And we were really trying to get at, are they making their own decisions? And this is an example of how patients are on a continuum, because we heard many women indicated that they wanted to take charge of their health. I have to look after myself. You know, in a sense, I'm taking care of my own health. These are women who wanted a lot of resources. They wanted to know what the reputable websites were. They wanted lots and lots of information. Other women were on the other end of the spectrum of decision making, and they were quite comfortable letting healthcare providers make decisions. So I have no choice. If they say do this, I will do it. I know that they are the professionals and they hold the information. So it's important to know that you have to judge your patients and the right amount of engagement. We shouldn't assume that all patients have the capabilities, interests, or goals to be as involved as we may think they should. And we certainly hear a lot of our patients say to their physicians in particular, what would you do if I was your mother? So we need to be prepared for that. A second trial that we did looked at trying to increase women's attendance at cardiac rehab intake. When I got into the business of women in heart disease and cardiac rehab almost 30 years ago now, less than 24% of eligible patients actually arrived at their first intake appointment for cardiac rehab in North America. And in reality, what that meant was less than 12% of eligible women arrived at their first appointment for cardiac rehab in North America. So that is a pretty dismal statistic. Through the years, we've done better, and we've actually moved to the point where suggesting cardiac rehab to all cardiac patients is in national guidelines. So it's in the CCS guidelines, it's in the American guidelines, UK, Australian. And Dr. Sherry Grace in particular from York University has done great work at promoting the idea of automatic referral for all cardiac rehab patients. Unfortunately, what we know is even the setting of automatic referral, only about 30% of patients actually get to their first appointment. So we designed RCT with a brief intervention between discharge from hospital and first appointment at cardiac rehab to see if we could get women to attend that first cardiac rehab appointment more reliably. What we did was it was a phone call, and it was talking to, it was designed to support women in making decisions about attending cardiac rehab. So things that we included in the intervention was that their physician had referred them and thought that this was an important intervention. We talked to them about what the benefits of cardiac rehab were. We talked from both a health perspective, but also from a social perspective and a peer support perspective. And we asked them some really concrete things like, how are you going to get to cardiac rehab? Do you have a car? Can you drive? Because certainly our geography in Ontario is such that many people live over 70 kilometers away from a cardiac rehab. Women in particular may not drive or may feel obligated not to take the family car. We heard that a lot. And the other thing we did was we talked to them about their next physician's appointment, and we used the take part methodology and actually helped them form questions for when they went to see their physician next. And in this study, we were actually able to increase attendance from 28% in our control group to over 60% in the intervention group. The patients who ended up not attending rehab were didn't think it was important, they thought it was too far to travel, or many were caregivers to others and were unable to get out of the house. So to us, this really showed that the importance of giving patients support, giving them the education, and involving them in the decision did make a difference to attending rehab. I'm going to move on to engaging the seldom heard. So integrating needs of patients, including gender equity, ethnicity, Indigenous heritage, and geographical challenges. These groups are often referred to as hard to reach, which actually unfairly communicates that there is something about them which makes their engagement difficult, and we know that that's not true. We prefer to use the phrase seldom heard, and this describes people who often experience barriers to public participation and engagement, or those whose perspective and ideas are often underrepresented in decision making. We say seldom heard because we believe that if we can use appropriate approaches, techniques, and tools, we can and should ensure full participation for anyone. Seldom heard people are often historically marginalized groups, such as racial and ethnic minorities, Indigenous peoples, the LGBTQ2+ community. People experience homelessness, those living with a disability or addiction, or silent majorities. And these are women, newcomers, the working poor, or young families. And it's always interesting to me that when you look at guidelines, women are still considered a special interest group very often in cardiac care. Even though we're 50% of the population, we have half the heart disease. Anyway, these patients, depending on the context, face barriers to meaningful involvement in decision-making by and with government. And I just bring us back to ensure the impacted have a say. Nothing about us without us. So when we think about engaging the seldom heard, it's talking about building trusted relationships, working together, allowing people two-way communication with patients and community partners, asking people about how they want to be involved, what's the best way to reach them. Working with community groups is incredibly important. Engaging people early or engaging groups early and allowing time for them to participate. We often think about engaging people at the last minute, and I'll tell a story about that in a minute. We want to ensure that we improve accessibility and consistency of engagement. And it's not expecting people to come to us, we need to go to them in our community. At Women's College Hospital, we actually run a clinic for the refugee population in Toronto, and it's called Crossroads Clinic. And we very early on recognized that sitting in an institution probably wasn't the best place to reach the refugees in Toronto. So now our physician lead, Dr. Rashid, and our 2 nurse practitioners actually go out to 3 of the hostels in Toronto where a lot of refugees are housed when they originally arrive, and they provide hands-on care in the hostels. And that's been incredibly well received. So everything from the hands-on clinical medical care that we think of to education, to providing education on nutrition, how they're going to shop in Canada, all those types of things, but really reaching out and going into the community. The idea of promoting effective, transparent engagement. So really helping people understand how their contributions are making a difference, so they're not seen as just a token. Help measuring and evaluating that engagement and feeding that back to people is all important. Benefits of more inclusive engagement include improved understanding, communication, and interactions, building trust and strengthening relationships between clinicians and the people, and also between government and policymakers and people. Consideration and integration of the vision and perspectives of diverse people and communities brings a broader network of knowledge and support to the table and mobilizes a comprehensive roster of community strengths and assets. More informed, data-driven decisions are grounded in community voice and context and informed by the lived experience. A more comprehensive understanding of community priorities and needs, as well as possible unintended consequences of a decision. Inclusive engagement improves access to the wisdom of individuals and groups with lived experience and offers a different perspective, ideas, and options. This often increases equity and increases participation and buy-in to our programs. Greater equity and inclusive engagement increases opportunities for everyone, which in turn leads to a stronger local economy, safer, more resilient neighborhoods, and sustainable growth. So 26 years ago, Dr. Len Sternberg, who's a cardiologist at Women's College Hospital, I was a nurse practitioner in an inpatient unit. We had 33 beds, which were mostly filled with women post-heart attack, and we talked to them about going to cardiac rehab, just because Len and I were big exercisers and we thought it was the right thing to do. And we found out that most of our patients didn't. Yeah, you know Len, right? Most of our women didn't go to rehab, and we found that there was a few barriers, so we actually thought, we're going to set up a cardiac rehab for women. And our physician-in-chief at the time struck a wonderful group to do this with a whole bunch of partners, notably no patients. I was the only woman on the group. And we talked about what cardiac rehab for women would look like. So we thought, you know what, this is an old-style rehab. This is a guy's gym. We're not going there. We're going to have something really nice. We're going to go for something fancy. And then I thought, really we should talk to some of these women and find out why our patients aren't going to rehab and find out really what they want. And so we did that. And this is what we heard. They want support, help, advice, guidance, and assistance. Yes, nobody mentioned the exercise word at all. That was not in any of the focus groups or heard by any of the 100 women we spoke to. We heard they wanted to meet other women. They wanted to talk to them about things that worked. They wanted to meet with dietitians. They wanted support. So we actually carved out a little bit of women's college, and we built a space for these women where they could talk to each other and support each other. And yes, because I could, we built a little exercise room for them as well. This room was actually overlooking Queen's Park, so we could do a little bit of political activism at the same time. So that's our mistake in engaging patients. We still had a good outcome, but we engaged our patients too late. But lessons learned. So engaging patients in research. Typically, when we think about patients in research, this is what we think about. Our patient as a data point. Let's collect some data and do something to them. But we really know that engaging patients in research is much more. And over the last decade or so, research funders are advocating for more active involvement of patients in research activities. Funders in the UK, US, and Canada all talk about the important ideas and roles that patients bring to the research table. Indeed, patients have an important stake in research, especially in research outcomes, because they are the ones that are most affected. They have the lived experience of healthcare that is different from the one that's usually seen by healthcare providers and offers a unique and valuable perspective to the research team. And the UK has been talking about involving patients in research since 1996. The United States established the Patient-Centered Outcome Research Institute in 2010 as part of the Patient Protection and Affordable Care Act. And in Canada, the Canadian Institute for Health Services Research started the Strategy for Patient-Oriented Research, or SPORE, in 2011. And it's allocated $60+ million and is organized over a provincial and territorial unit point. I don't know how many of you read CMAJ, but last month in November, the supplemental was on the SPORE projects, and they have reviewed 17 projects talking about how they've involved patients in their research. And it's actually a great, the whole journal, the whole volume is a great read, talking about some real successes, but other people are talking about the challenges of involving patients in research, and there's a lot of great lessons to be learned. So patients have a personal experience of disease that can enhance their study design, practicality, recruitment, data interpretation, and dissemination. We have a researcher at Women's who does work with the women in HIV population, and she actually has trained women with HIV to be her research assistants. They recruit, they collect data, and they help interpret data. And she's found it's a huge success because these women know how to find other women with HIV. Sorry, this slide is clearly not working. So again, engaging patients in research is a continuum. There we go. Information, people can be a participant, or they can actually get to leading and supporting the research. As an active participant in research, they can potentially lead the improvement in credibility of results. They can have higher rates of enrollment and retention, and the direct applicability of results to patients. Core areas for engagement are in the governance and decision-making, committing to engage patients in peer review and priority setting. But we know there's a lot of challenges to engaging patients in research. We need to enable their contribution. Access and communication can be issues. Patients need the ability to access terminology. We have a lot of research speak, which can be worse than medical speak. Steering group meetings, attending them can be an issue. Training in research and funds to travel. Even communicating. You know how often we have those hallway conversations about research? Patients, if they're on part of the research team, they're just not going to be there. And the timeliness is an issue as well. When we think about research, we think about trying to get things through the steering committee, through research ethics, and some people worry about having a patient involved on the research ethics, on the steering committee because they haven't gone through research ethics. The relationships for patients can be interesting because oftentimes they're recruited to be a member of a research team because they're involved with a clinician. So if they're in the clinic, the clinician, it's a different relationship. The clinician is usually their doctor, but when they're sitting at the research team, they should be a colleague. So how do you differentiate that as a patient and as a physician? There's a lot of discussion around tokenism, so just collaborating to be politically correct and get the grant money, and a lot of patients do feel that that's what's happening. So they worry about that, and there's been quite a bit on the Twitter community over the last 4 weeks about patients talking about tokenism and actually pushing back and saying, if you're invited to be part, push back and really ensure what your role is. So I was surprised in prepping for this talk how much is out there from patients talking about that whole idea of tokenism. And patients also worry about their ability to contribute. So they're not sure that they're going to be able to contribute, so we need to support them by giving them education and time. So as a framework for a solution, we think of first, so we need to facilitate patients to be partners in our research, identify them, respect them, support them with time, and also to train them to be part of our research team. And I'm going to show you a short video now, again with one of my ended up as a success, but we did a project. We were invited by a mosque to come in and provide exercise for their male members of the mosque. And we said, you know what, we're really interested, but we'd love a chance to come in if we can come in and work with the women in the mosque as well. And we have an opportunity to do it as a research project. So we actually engaged the elders of the mosque as part of our research team from the very get-go. We sat at the table, we designed the project, we designed the intervention, we got some money, and we moved forward. And then we got into the mosque, and the women of the mosque took our intervention and threw it out the window. Told us we were trying to deliver it at the wrong time, we had the wrong exercises, we had a total misconception. And these women were fantastic because the elders of the mosque had wanted them to exercise in the basement, which was a little grungy area. And they went and they said to the elders of the mosque, no, we're exercising in the sisters' room. We're going to do it at this time. And we're bringing in my research assistant went in to deliver the intervention. So really learning about which patients to engage and how to engage them. And I'm just going to show you this short video that talks.
I was born in Bombay. I moved to Canada 15 years ago. I love this country.
3-4 years back, I had a very bad pain on my hands. Afterwards, I went to the doctor. The doctors gave me medicines, tablets, and with that, too, it didn't help.
At the end of the day, I would be so weak. So having that stamina at the end of the day, I just didn't have it. I would be so tired and so exhausted.
If you're living in Canada, the risk of developing diabetes is at 5%, but if you're a South Asian living in Canada, the risk of developing diabetes is at 14%, and this is much higher for South Asian Muslim women.
Everybody needs exercise. Exercise is medicine. We know from validated research, if we can improve her functional capacity by even a small amount, we can decrease all-cause mortality and morbidity.
However, when it comes to South Asian women, particularly those who are part of the Islamic community, they have added barriers that are unique to this population for the fact that they are unable to exercise in mixed gender settings, have religious modesty, and therefore it's imperative that we're able to find an avenue for these women.
I think the difference between exercising at a mosque and any other type of gym is you have the fact that it's a comfortable space in their community. That mosques, we go there to pray 5 times a day, and it's people in the mosque are people you're already familiar with, they're community members, and when you're working with your community, you already feel comfortable with them.
In our exercise intervention at the mosque, we were actually just trying to get women to the point where they met Canada's physical activity guidelines. When we went into the mosque and surveyed women, we realized that only about 10% of women actually met these guidelines. At the end of our 6-month intervention, we got about 42% of the women are now meeting those guidelines. It's still not where we'd like to be, but it's certainly a huge improvement and statistically significant.
When I started my exercise, it was so nice. I felt so relieved, and my pain also, it went. And now I can move my hands up and down everywhere.
If I'm doing something for myself, I feel more confidence, I feel more motivated, okay, I wanted to do it. And if I'm happy, then I can keep my family happy and everybody's happy in my house.
So the success of that research project was when we finished our funding, we were there for 6 months. They hired the mosque hired one of our research assistants to stay and do the exercise program. So that was our big measure. That's it for me. Thank you very much.